Good afternoon, and thank you for joining us today in this Image Challenge live stream event from Retina Physician. My name is Mari Rodriguez, and I will be your host today. I am a retina specialist with Vitrio Retinal Associates, and I practice in Massachusetts. I have no financial disclosures. As you know, our plan is to post an image challenge each month and then discuss the diagnosis and management using this platform. We would love to hear your thoughts online. You can follow us on Facebook, LinkedIn, YouTube, and Twitter. You're also welcome to write on the chat and share your thoughts with us during this event. Today, we will be discussing the case of a 74-year-old lady who was referred to us for retina evaluation and possible surgical intervention. Her visual acuity in the right eye was 20/60, and she had normal intraocular pressures. Anterior segment was significant for bilateral pseudophakia, but otherwise it was unremarkable. A blunted fovea was noted on dilated fundus examination, and a macular OCT revealed vitreomacular traction and also an epiretinal membrane nasally with inner retina falls. Some cystic changes were noted in the fovea, and which were arising from the tension caused by the vitreomacular traction. At this point, we discussed possible surgical intervention, which would include vitrectomy and membrane peel. So VMT syndrome can be categorized into V-shaped with focal adhesions of less than 1,500 microns or J-shaped with broad adhesions of more than 1,500 microns. By this category, our patient presented with a broad-based J-shaped VMT, which has higher correlation with ERM formation as well. A recent study by John et al. From Bascom Palmer showed that VMT is spontaneously released in 30% of grade 1 VMA, 30% of grade 2 VMA, and 57% of grade 3 VMA patients. Based on this, initial observation remains a viable option and may be offered to patients with mild symptoms that do not have too much distortion and that are able to continue their activities of daily living. And surgical intervention remains an effective therapy for these patients, and most patients experience a degree of visual improvement after surgery if this avenue is taken. Finally, medical therapy with oxyplasmin was described as a viable option, but given the high rate of complications after administration of this medication, this was discontinued by the manufacturer. So our patient was ambivalent about surgery. And then after we discussed the risks, benefits, and alternatives, she decided that she wanted to observe. She was not bothered by her vision, and she did not think that she had any trouble with the activities of daily living. So we observed, and when she returned 6 months later, her vision had improved to 20/25. And as you can see, the VMT had released on its own, and the following OCT did still have a very, very, very mild ERM, but her visual acuity was 20/25, and she was pleased. So thank you for tuning in today. You can leave us a comment online via our multiple platforms, and we hope to see you again in another month as we discuss another interesting case. Thank you.